when we looked back at the history that we collected, because we collected the presenting problem but also history of any other presenting problems, we saw that an additional 20% of those that didn't meet criteria for a mood disorder currently had a depressive episode or a history of a mood disturbance in the past. What we also saw was this pattern of individuals that had been treated with antidepressants, where the depression had successfully remitted, but the anxiety symptoms had increased. So it was almost like the depression went down, but the anxiety symptoms increased, and so they actually met criteria for an anxiety disorder, though there were some symptoms of a mood disturbance, not enough to make a clinical diagnosis of depression. I just wanted to look very quickly at the symptom profile of what we did see with the individuals that we did interview. On the left-hand side, I have of the slide, I have the DSM, the ICD-10 criteria. So what would we would expect in typically developing individuals, or the symptoms that we would see in typically developing individuals with depression. However, what we also saw in cases with intellectual disability or those that have a severe form of autism and communication difficulties were symptoms that were expressed very differently and were more consistent with the atypical symptoms that were described in the DMID. I'll quickly just go through some of them, as I think it's important to point out the differences in presentation. So, for example, in high-functioning individuals, we may have seen a reported of low mood, both by the young person as well as the family. But in some other cases, the family may have described the other person in terms of observing them as having a sad facial expressions, or crying a lot, or having a flat affect, but not being able to necessarily be able to identify any triggers for that, or the crying seemingly occurring for unknown reasons. In terms of irritability, the person may have been described as being grouchy or having angry facial expressions, and what we did see as well was an increase in agitated behaviours, particularly assault towards the parents, and also some destructive behaviours like throwing furniture around and breaking things. I'll just move down to the sleep and appetite disturbance. In many cases, what we did see was an increase in problem behaviours during the nighttime routine or very early in the morning, so that the young person would wake up or have early morning awakenings and engage in problem behaviours at that time. In persons where we saw an appetite disturbance and that had an intellectual disability, this was often expressed in terms of refusing meals at mealtime or becoming extremely distressed at mealtimes. I also want to look at the criteria of expressed worthlessness or guilt feelings. Again, in the high-functioning individuals, we were able to see, or they were able to express the negative statements that they had about themselves, or the negative statements that they made to their parents or their carers. Some individuals with an intellectual disability, moderate or mild, were able to identify themselves as being bad or saw themselves as being bad. But a lot of individuals that had they were quite low functioning obviously don't have the cognitive levels consistent with the capacity to express feelings such as guilt and worthlessness. And what we saw in those individuals was an excessive need to seek reassurance from the parent. And if I've got time, I just want to describe one particular young person that I did see who had bipolar with the most recent episode that was depressed. And during the entire interview, pretty much every minute he would ask his parents if he was an okay boy and if he did anything wrong, and he would repeat that. And the interviews go for 4 hours, and so it was actually quite an exhausting experience. And I guess I want to highlight how difficult it must be for these parents that actually live with this day to day, and how difficult it is to actually reassure this young person. There was basically nothing we could have said that would make this person less distressed or to feel better about themselves at that point in time. We also looked at...
Dr. Karas, you have 5 more minutes.
Thank you. We also looked at atypical symptom expressions of depression, which were more looking at a change or an exacerbation of the core features of autism. So reduced talking or increase in repetitive behaviours. Some high-functioning individuals were actually able to very articulately describe a loss of motivation or falling out of life, was one way that they described it, and also express some of the ruminating thoughts that they did have. I'm going to have to go much quicker because we're running out of time. I wanted to present the initial case of a high-functioning individual. He was I'm going to call him Sam. He was a 15-year-old boy, and at the time of the assessment, he presented as dysthymic. However, he was able to engage with a clinician. His mother reported that his mood had progressively deteriorated over the past month and a half, described as being as depressed more days than not, and also this depressed mood was accompanied by appetite disturbance, hypersomnia, fatigue, psychomotor agitation and feelings of inadequacy, which, as we can see on the first slide, are quite consistent with a DSM criteria of depression. The other things that we did see and Mum described was intermittent episodes of irritability and reduced talking or explosive aggressive behaviours, which is again more the atypical symptoms which we would see in the DMID, taking into account intellectual disability. But we also saw other symptoms when we talked to Sam on his own. He was able to describe his thoughts in terms of an argument occurring in his head. He talked of intrusive suicidal thoughts, but also talked about a need for routine and consistency, and that was quite intense. And Mum was also able to verify that his need for routine had intensified quite a fair bit, as his ritualistic behaviours had as well. And he tended to isolate himself a lot more. Unfortunately, Sam was hospitalised a couple of months after the assessment because his depression worsened. He was given a diagnosis at the time of a major depressive recurrent disorder superimposed on dysthymia, which is what clinically would be referred to as a double depression. I wanted to also present a young girl with an intellectual disability alongside the high-functioning individual, just so that we can see the difference in the symptom profiles. This is Angela, who is a 17-year-old female with moderate ID. Her mother reported drastic changes in her functioning, particularly over the last 10-month period. There was episodes of aggression, tantrums had progressively increased. Her affect was flat, and she was crying intermittently without any explanation by her parents or any seeming triggers. Her appetite had also decreased, and she had become increasingly restricted in the food that she would eat. She also engaged in increased self-harm behaviours and avoided leaving the house, particularly stopped Mum from leaving the house as well. I won't go through the entire case because we don't have time, but she was also described as having lost interest in activities she previously enjoyed, and also an increase in problem behaviours at bedtime. Now, what we see here is a change in the baseline levels. So, although Angela was able to use the feeling thermometers to describe being very, very angry and very, very sad, she wasn't able to articulate that verbally. So what we were able to get from that was that she was feeling angry and she was feeling sad, and it was consistent with Mum's description. She was given a diagnosis of major depressive disorder, which is most likely to develop into a dysthymia if not treated, and a separation anxiety as well. So what we can see really is a different symptom profile for very similar diagnoses between a high-functioning individual and an individual that has an intellectual disability. Just to point out as well, she had no history of medical conditions, and the reason why we collected medical history information is because some common medical problems may provoke or mimic symptoms of depression, so we needed to rule that out. So some concluding remarks and take-home messages is that I want to leave you with is that the DSM criteria was able to be used to make a diagnosis of depression in autism, though atypical symptoms had to be taken into account, so complementary nosologies needed to be used. But I think it's important to start using the standard or gold standard criteria that we do have, so that we are able to replicate this information using consistent diagnostic criteria. And this will hopefully lead to the development of screening instruments for people with autism that have mood disorders. What we also saw was symptoms most commonly associated with autism changed during the mood disturbance. And of course, this is not specific to depression necessarily, but a change from that baseline may be a marker of the presence of psychopathology in these young people. And I guess I wanted to highlight the levels of psychopathology that we're seeing. So the autism, in some cases the intellectual disability, and then other Axis 1 disorders. And I think that this, when left untreated, can affect long-term outcomes of people with autism. So, for example, in some cases they had lost a place in residential care because of their problem behaviours and isolation. And also highlight that the additional stress that an additional Axis 1 disorder can cause for the individual themselves, but also for their carers. That's just some information about where the research was conducted at the Centre for Developmental Psychiatry. I'd like to also acknowledge the co-investigators, Professor Bruce Tong, Dr. David Mosley, and Dr. Nicole Reinhardt, who's with us today as well. And any questions and feedback or comments are very welcome. Thank you.